Thank you. Start, ma'am.
Yes, ma'am. So coming to the details, I'll be presenting a case of Mr. XYZ, who is a 76-year-old male hailing from Dodbalapur, who is a retired school teacher by occupation, who was admitted on 21st of this month and was examined on 24th of this month. He came with the chief complaints of drooping of the eyelid since 1 month. He noticed double vision since 1 month. He also noticed slurring of speech since 20 days and difficulty of swallowing food since 20 days. History of presenting illness. An elderly right-handed gentleman. He was apparently asymptomatic, performing his daily activities. When he initially noticed drooping of the left eyelid, initially when he saw himself in the mirror, which was insidious in onset, and it progressed to involve both the eyes after a period of 10 days, in such a manner that the patient noticed that the drooping of the eyelids used to worsen on frequent movement of the eyes, for which he was taken to an ophthalmologist, and he underwent some tests and was told to have a problem in the brain and was referred to a neurologist. During this period, he also said he had some difficulty in reading newspapers as well, and his friends had noticed that there was the drooping which was more in the left eye compared to the right eye, which the patient also subsequently noticed on seeing himself in the mirror. Following this, simultaneously during this episode, when the patient started developing drooping of the eyelids, he started noticing objects as to this diplopia. He noticed that the objects were next to each other, which was insidious in onset. They began at the time when the patient noticed the drooping of the eyelids. It was painless, which it improved on closing either of the eye, and also improved after washing the face with cold water. It was episodic in nature, such that it worsened on reading a newspaper for a constant amount of time. As he was reading for about 15 to 20 minutes, continuously the patient noticed difficulty and double vision worsening. And also, however, he did not notice any difficulty in identifying the words, colors, or contrast. The patient also noticed slurring of speech since 20 days in such a manner that he was unable to speak properly, which was insidious in onset and variable or episodic in nature, such that the slurring or frequency of the speech worsened on continuously speaking for more than 3 to 5 minutes and improved after a rest of about 5 to 10 minutes. The patient says he is able to comprehend, read, write, name and repeat words. Patient also further subsequently developed difficulty in swallowing that was insidious in onset, which was predominantly more for liquids than solids, such that he felt a choking sensation in the throat and was completely unable to swallow in one gulp. And since then, he's been having a reduced appetite. And also, he says he feels like regurgitating the food because he's unable to eat. There is no history of any nausea, vomiting, reduced hunger, or satiety. There is no history of pain, redness, swelling, or trauma to the eye. No history of abnormal behavior, loss of consciousness, or involuntary movements. There is no history of drooling of saliva, deviation of angle of mouth, reduced hearing, nasal twang, or change in voice. There is no history suggestive of any sensory involvement in the form of either positive or negative symptoms. There is no history of any history suggestive of motor system involvement like proximal or distal muscle weakness in the form of difficulty in combing hair, buttoning or unbuttoning shirt, mixing food, gripping objects or writing, and in the lower limb like squatting, sitting, walking or gripping slippers. There's no history of difficulty in walking, giddiness or frequent falls that were noticed. There's no history of fever, recent significant weight loss, night sweats or chills. There is no history of breathlessness, orthopnea, chest pain or palpitations. There is no history of abdominal pain or altered bowel habits. No history of any previous hospitalizations. A patient is not a known case of diabetes, hypertension, asthma, tuberculosis, or seizure disorder. He has never been admitted in the hospital in the past. Family history, there is no history of similar complaints in the family. He is born out of a non-consanguineous marriage. There is history of type 1 diabetes, vitiligo, and autoimmune thyroiditis in 2 of his children, probably autoimmune polyendocrine syndrome, that started at the age of about 15 for both of his children. Personal history, the gentleman consumes a mixed diet. The sleep has been adequate. The appetite has reduced since the past 1 month, with normal bowel and bladder habits, and he denies any history of high-risk behavior or any deleterious habits. There's no history of any drug allergies or regular consumption of drugs. Should I summarize the case, ma'am?
Yes, ma'am.
Yes, ma'am. So here we have an elderly.
So you will analyze the symptoms.
Yes, ma'am.
Okay. You told me that the first symptom is drooping of eyelid.
Yes, ma'am. So
would you like to analyze that?
Yes,
why do you call this patient has got a drooping?
The patient has noticed that one eyelid initially was lower than the other, and he compared it with his previous. He has noticed it in the mirror, ma'am. So that is what the patient had said, ma'am. He's noticed.
Of course, one point is subjective. When the patient noticed that one eye is more lower than the other eye. But are there any criteria? Are there any criteria, ma'am, to call it as drooping? You know that partial ptosis and complete ptosis, yes. Are you knowing?
Yes,
so when do you call a patient as having partial ptosis, complete ptosis, pseudotosis, psychogenic ptosis, blepharospasms, no? These things are all to be differentiated. So when do you call it as a partial ptosis?
Partial ptosis occurs.
So definitely he has a ptosis, yes, and the ptosis is asymmetrical. So yes. These are the two things, because one eye was lower, that is why he noticed that. Yes. So it is asymmetrical ptosis. So normally if it is symmetrical, let us say, when will you say that there is a ptosis?
Whenever there is either a weakness of the, either it can be a neurogenic cause, a myogenic cause, or at a lesion at the neuromuscular junction, ma'am. So if it is a neurogenic cause, either we think of the sympathetic chain, sympathetic.
When the patient has the upper eyelid coming below the 10 o'clock to 2 o'clock position. Okay. So if the upper eyelid comes below 10 o'clock to 2 o'clock position, you call it as drooping. It may be physiological, it may be pathological. Some people have familial ptosis also. Okay. So the upper eyelid should be above 10 o'clock and 2 o'clock position. If it is coming below that, it is ptosis. That is called partial ptosis. Okay. If the pupil is covered, that makes the patient blind. It need not completely cover the eyeball. Okay. If it covers the pupil, you call it as complete ptosis. So in our patient, it did not cover the pupil. So the first information, one we called is an asymmetrical drooping. Second, it is partial, because it did not cover the ptosis and it did not make him blind.
Yes, ma'am.
So that is the second information. So when do you call it as pseudotosis? I want to tell pseudotosis. What of that term? Pseudotosis, blepharospasm, blepharochalasis, psychogenic ptosis, so many terms are there, no? So partial ptosis, complete ptosis, we learned. Pseudotosis is what you told, when the ptosis is due to sympathetic paralysis, Muller's muscle. So what are all the points of that? Our patient is definitely not having that, because it will be very mild ptosis and it will involve the upper eyelid and the lower eyelid. Because the Muller's muscle is present in both the upper eyelid and the lower eyelid. So what will be the manifestation of ptosis in the lower eyelid? The lower eyelid will move up. So unlike the upper eyelid coming down, lower eyelid will move up. So pseudotosis is a very never complete, always partial. very mild ptosis, involves both the upper eyelid and the lower eyelid, and voluntarily patient can correct it because voluntary muscles are working. Muller's muscle is an involuntary muscle. The voluntary muscle which prevents ptosis is levator. So the levator palpebrae superioris can open the eyelid. So these are the features of pseudotosis. Upper eyelid, lower eyelid, never complete, and voluntary correction is possible, and never the pupil gets involved. That is pseudotosis. Have you heard of blepharochalasis? Blepharochalasis is drooping which happens due to mechanical cause. You may have a dermoid in the upper eyelid, or you may have a skin fold. That is old people when they become when they lose their subcutaneous fat, the upper eyelid skin becomes folded and sits on the eyelid, and it will push down the eyelid. The treatment is only removal of the dermoid or shorten the upper eyelid skin. That is called blepharochalasis. If you do not know this, many times they get investigated for all kinds of neuromuscular diseases. So this happens in older people. Then psychogenic ptosis. Somebody has read, for example, those people who are interested in internet, somebody hit me, after that I had developed ptosis. So that is psychogenic ptosis. Psychogenic ptosis is produced by the patient, and the muscle involved is not levator. In pseudotosis, it is Muller's muscle. In organic ptosis, it is levator. In psychogenic ptosis, it is active contraction of the orbicularis oculi. So patient will contract the orbicularis oculi. So it can be partial, it can be complete, and it will always involve both the upper eyelid and the lower eyelid. So psychogenic ptosis is active contraction of orbicularis oculi. Depending on how much he contracts, it can be of any range. That also does not involve the pupil, and it involves upper eyelid and lower eyelid. Then third cause for the eyelid coming down is blepharospasm. Senior citizens, they may be taking some sleeping tablet, or they may be taking the drugs used for gastric motility disorders. They all produce dyskinesia, involuntary movement, or Meeks syndrome, oromandibular dyskinesia can start with blepharospasm. There the ptosis is associated with spasm. You can see the spasm of the eyelid muscles, and the patients can have triggers. Patient will tell, when I put my thumb in the upper aspect of the nose, I can keep, because they are called sensory tricks. They are called sensory tricks. So the blepharospasm can be corrected by sensory tricks, and the spasm will be visible. The muscle will be in contracted position. So these are the things. Among all this, we think that our patient had a partial ptosis. It is asymmetrical ptosis, and it was fluctuating. Whether it involved the lower eyelid, it doesn't appear that the lower eyelid was involved. It doesn't appear that there was a spasm. So these are the points we are getting from the first symptom. So when there is an asymmetrical ptosis, you have to also remember the nerve, third nerve. Symmetrical ptosis may be muscle, neuromuscular junction, mitochondrial disorders, oculopharyngeal myopathies. All those conditions are there. But when it is asymmetrical, you have to remember a third nerve palsy. Especially an old man, if he has diabetes, they can have third nerve palsy. So the second thing that we include into the drooping, apart from the phenomena we studied, is that drooping associated with pupillary involvement? So is that drooping with pupillary involvement or without pupillary involvement? So associated pupillary involvement is favoring a third nerve palsy. So at this point, you can also ask, is he having an intrinsic lesion in the third nerve nucleus? Would you like to tell me, ma'am? So senior person, he can have a metastasis in the midbrain, the nucleus of the third nerve. What do you call the nucleus of the third nerve model, ma'am? It is just a revision. I am trying to revise. Warwick's model. Okay. So you know that the third nerve nuclear arrangement is called Warwick's model. Very, very peculiar. Each muscle has got a nucleus, even though the whole nerve is a single nerve. Each muscle has got a different nucleus. Superior rectus another nucleus, inferior rectus another nucleus, no? And levator has got a ventral caudal bilateral. Levator palpebrae superioris has got a bilateral representation. And Edinger-Westphal nucleus has got a bilateral representation. And superior rectus of nucleus of one side supplies the superior rectus muscle of the opposite side. So at the nuclear level, the unique features are each muscle has got another one nuclei, and levator palpebrae superioris is bilateral and superior rectus is contralateral. So and Edinger-Westphal nucleus is bilateral. So if I ask you, would you like to consider as a differential diagnosis nuclear level Turner palsy for this patient? You will say yes or no. You will say no. No, because levator is bilateral. So when there is a nuclear Turner palsy, the drooping will be bilateral. You are able to hear now what I am telling?
Yes, ma'am.
The nuclear Turner palsy, the drooping will be bilateral. It will not be unilateral. Or it can be individual muscle palsies. Or it can be pure pupillary involvement and no muscle involvement. Or if the superior rectus is involved, it is opposite side. So that is called pseudo-Parinot syndrome. Because the superior rectus nuclei of the one right side is closer to the inferior oblique nucleus of the right side. They are next to each other. So a nuclear lesion which involves the superior rectus of one side can involve the adjoining inferior oblique. Inferior oblique is an elevator. So bilateral elevator paralysis will happen. But it is lower motor neuron. Whereas Parinot, it is upgaze palsy. Here it is an LMN palsy. So that is called pseudo-Parinot syndrome. So nuclear Turner will be pure pupil or individual muscles or pseudo-Parinot syndrome, or if there is a ptosis, it will be always bilateral. So my patient is not, is an asymmetrical ptosis. It is definitely not in the nucleus of the third nerve. So can it be fascicular third nerve? It can be. We cannot say, we have to examine the patient. It can be fascicular third nerve. We call it as 4 Ds. Drooping of eyelid, dilated pupil, divergent skin and diplopia. So third nerve cannot be excluded until we examine the patient. But you said that there is a fluctuation. So it can be neuromuscular junction. Can it be muscle? Very unlikely. Because in the muscle, you have got mitochondrial disorders, you have got oculopharyngeal myopathies. But the oculopharyngeal myopathies can manifest later. Mitochondrial diseases manifest early, but they are all symmetrical. Because it is a symmetrical ptosis, now we are left with 2 options, whether it is in the third nerve, fascicular part, not in the nucleus. Nuclear third nerve will produce bilateral ptosis. Because it is unilateral ptosis, it is either in the fascicular third nerve or it is in the neuromuscular junction. It cannot be muscle, it cannot be mitochondrial disorders. This point is clear, no? The Warwick's model you should remember. And in the nucleus of the third nerve, levator is having a single nucleus for both levator. So nuclear third nerve cannot produce unilateral ptosis. It always produces bilateral ptosis. Or it may not produce ptosis. It may just produce an individual extraocular muscle palsy because each nucleus supplies one muscle. And if the superior rectus is involved, ipsilateral elevation can be affected. You call it as a pseudo-Parinot syndrome. So is it clear?
Yes, ma'am.
So the first symptom, we think it is either in the fascicular third nerve or it may be in the neuromuscular junction. Okay, so we'll go to the second symptom is double vision.
Yes, ma'am.
So double vision, how are you going to analyze, ma'am?
First is we think whether it is painless or painful first, ma'am.
Yes.
Then the second question we ask is whether it is monoocular or binocular, ma'am.
Yes.
So monoocular is when we are seeing with one single eye, then we get diplopia.
Yes.
So that is usually secondary to a local cause in the eye, ma'am, like either cornea or refractory medium involvement, anything.
Yes.
So whenever there is a bilateral, binocular.
So when it is uniocular, you will think of psychogenic ptosis, psychogenic double vision also. Okay. Patient will say one eye is closed, still double vision is there. But ocular causes, they are more polyopias. than exact double vision. Cornea, lens, retina, they can produce polyopia, and the unique feature of that is there is a glare, because it is a refraction in the cornea or the lens that is producing that. So mostly they are polyopias, and they will have a glare in the false images that you see. And ocular cause may be very evident for us. Then another cause for uniocular will be occipital lobe. Occipital lobe, visual association area, and there is plinium of the corpus callosum, that is called sliding hemifield defect.
Okay.
Supposing you cut off the plinium of the corpus callosum, what happens is two fields float. You will have a right hemifield and you have a left hemifield. If there is any doubt, you ask me, ma. Because am I audible? Clear, no?
Yes,
So when there is any doubt, you stop me and clear me. Yes, because two fields are there, and these fields are united so that you have a holistic vision. Okay. But when you cut the corpus callosum, you have a right hemifield and you have a left hemifield. But those two fields are not united properly because of the lesion in the corpus callosum. So there are floating two hemifields. In the area where these two fields come and overlap, the images slide. So you will see the images are 2 or 3. That is called sliding hemifield defect. That will be expressed by the patient as a multiple objects. So uniocular will be ocular causes where there is a refractory glare will be there, or it can be a neural cause when it is occipital lobe polyopia, or it may be sliding hemifield defect. Now you come to the binocular.
Binocular. So
binocular.
Binocular usually it is a neural cause, ma'am. Binocular, yes. Usually neural or neuromuscular cause.
Yes, invariably it is due to a neurological cause. Binocular diplopia is generally very, very unusual in any other cause. It is neurological cause. Agreed?
Yes, ma'am. And here,
and what kind of neurological, upper motor or lower motor? When double vision to happen, there is lack of parallelism in the visual axis. So lack of parallelism in the visual axis. So the seen images of both eyes are put in different parts in the retina. Instead of they coming into the principal fovea on both eyes, in one eye it will be in the fovea, in another eye it will be in the retina. So because of the lack of parallelism of the visual axis, images are perceived in two different sites in the retina, and brain thinks it is two different objects because it is projected. So it is, when do you get lack of parallelism?
When either the eye is deviated, any obvious
yes. So when you have a squint. Yes. In other words, your answer is correct. Lack of parallelism happens when there is a squint. What is the cause for squint commonly?
Either it is muscular weakness or usually a muscular weakness of extraocular muscle.
So paralytic. So usually lack of parallelism is due to a squint, and the squint is 99.9% of the time it is paralytic squint. Paralysis of any one of the extraocular muscles. So you can get double vision, binocular, when there is lack of parallelism of the visual axis, which is due to squint. And why the squint is happening? Due to paralysis of the extraocular muscle. There are exceptions. There is a thing called skew deviation.
Yes,
what is skew deviation?
Yes, whenever there is like brainstem involvement.
Yes.
There we can.
So skew deviation is due to vertical disconjugation of the eye due to a supranuclear cause. That is a definition. It is upper motor neuron. So that is an exception. The only if you do NIMHANS neurology entrance test, what is the upper motor neuron cause for double vision? You have to say skew deviation. Because everything else is lower motor neuron. Okay. Why do you get skew deviation? Would you like to tell me?
Not sure.
It's a very interesting thing. You see, normally to have a three-dimensional percept of the world, in human beings, we use the visual association area. Yes, occipital association area. Whereas in lower animals, you know the houseflies and all. No. Housefly, if you have seen, When they sit near a food particle, they will be rotating their head.
Yes, ma'am.
Because their occipital cortex is not developed. They have a compound lens and they rotate eye and use the compound lens to measure the volume of the food particle.
Okay.
So this is, in that situation, one eye will be moving up, another eye will be moving down, and the head will be tilted in different angles, and it understands how much food is there.
Yes.
But this is suppressed in human being. Nucleus of Gajal. The center for this is nucleus of Gajal in the midbrain, which you told correctly. But this is suppressed in human beings because we have got the occipital cortex, we have got the frontal lobe. So we can decide how much we want to eat and where it is. All those things we can analyze using the occipital cortex and the frontal lobe. So this is suppressed. So when there is a brainstem lesion that disconnects the dorsal dorsal interstitial nucleus of Gajal from the occipital cortex, with reference to the volume assessment, you become uninhibited. So uninhibited nucleus of Gajal. So you become like the housefly. Rotate the eye, rotate the head. So this is called skew deviation. So skew is vertical disconjugation of the eye due to supranuclear cause. So how do you know it is not due to muscle paralysis?
We have to ask the patient to lie down supine and
Yes.
sit during examination. Ma'am. That time, if there is usually in skew deviation, I think on lying supine, there will be change in the eye, ma'am.
So as you know, in muscle paralysis, there is a maximum deviation of the false eye, false image when you move the eye in the plane of action of the paralyzed muscle. Supposing right lateral rectus is paralyzed. When you move the eye, even though double vision may be experienced in all planes, when the patient moves the eye in the plane of paralyzed muscle, that is towards the right side, the separation will be maximum. Whereas here it is a supranuclear disconjugation. There is no plane of maximum action of any paralyzed muscle because there is no muscle paralysis. So there is no plane of maximum separation. So skew deviation, double vision is always vertical diplopia, never horizontal, and it remains constant in all planes of action because the skew does not change whether you are looking up or looking down or looking to the right or looking to the left. So 2 points. One, it is always vertical diplopia and this plane of maximum separation is not there. It is uniform in all planes. So that is the supranuclear cause for diplopia. Now come to infranuclear causes. Would you like to analyze how many muscles are there? What all questions you will ask more in this patient to know which muscle we are going to incorporate? So we are thinking whether my patient has got a nerve disease or a muscle disease or a neuromuscular junction disease. All those queries are there.
Yes,
so we want to find out who is the culprit here.
Yes, ma'am.
Tell me, ma'am.
So
how many extraocular muscles are there? 12.
12, yes, ma'am.
You see, 4 horizontal muscles and 8 vertical muscles. So if it is due to an element diplopia, it could be 12 muscles, 4 horizontal muscles and 8 vertical muscles. Any one of them can be paralyzed and lead to diplopia. So now we are thinking it is not a skew deviation, it's a diplopia due to neuroparalysis. So which could be the culprit, 4 horizontal or 8 vertical or any more of them you want to know. So what all questions you will ask? It's a binocular diplopia. So horizontal means right medial rectus, right lateral rectus, left medial rectus, left lateral rectus. These are the 4 muscles.
Yes, ma'am.
So we will ask what all questions? Tell me, ma'am.
Movements of the eye, the diplopia worsening with any one of the direction of movement, either looking towards the right or left, ma'am.
Yes.
So that time either it will be, like in case if it is towards the right, either the right lateral rectus or left medial rectus, ma'am.
Yes. Good.
That is in the horizontal.
Then next thing, you will ask where is the false image?
False image.
You heard of cross diplopia? Medial rectus is a muscle which produces crossed diplopia. When I am looking to the right, I am outer image is the false image if the right lateral rectus is paralyzed. But if it is a left medial rectus, it is an inner image. So that is called the false image is inner. That is called cross diplopia. So it could be four muscles in the horizontal plane. First question you will ask the patient, do you have a horizontal diplopia or a vertical diplopia? If the patient says my diplopia is horizontal, then you can cut off the 8 vertical muscles. That is the superior rectus, inferior rectus, superior oblique, inferior oblique, 4 on right side, 4 on the left side. So patient's diplopia is horizontal means out of the 12 muscles, 8 muscles can be cut off. Only 4 muscles could be the culprit. Then you ask next question, is the diplopia worse while looking nearby or while looking far off? If the diplopia is worse when looking nearby, it belongs to the medial rectus. While looking far off, it belongs to the lateral rectus. That is the second point. Third point is what you told. If the patient says that while looking to the right side, I have maximum separation of the double vision and the false image is outer, that is right lateral rectus.
Okay.
And if the patient says my diplopia is worse when I am looking to the right eye, to the right side, but my false image is inner, then it belongs to the left medial rectus. Then we have another point, we call it as null position adaptation. Now, when there is a diplopia, the brain will try to correct so that it sees the environment clearly. For that, so many techniques are used. One is the head tilt. So you tilt the head so that double vision becomes less. That does not happen for all muscles, for some muscles only. That is called null position adaptation, where the images are superimposed. So if there is a lateral rectus palsy, which is producing the horizontal double vision, there is an ipsilateral head tilt.
Okay.
But medial rectus cannot be adjusted by head tilt, so there is no head tilt. So between the 4 horizontal muscles, now you understood, no? Patient says horizontal diplopia, then 8 muscles are out. And he says it is worst while looking far off, then it is lateral rectus. And you look to the right and then it is the worst, it is right lateral rectus. And you tell the patient to simply rest and he sits with the head tilt to the right side, it confirms it is right lateral rectus. So like that each muscle you can apply. So 4 horizontal muscles can be tested. Am I clear, ma'am?
Yes, ma'am.
So when there is a horizontal double vision, if it is really a true horizontal double vision, when the patient is resting, there will be a horizontal squint. So when you examine, you have asked all these things and you look at the resting eye position of the patient. If it is true that he has a horizontal double vision, he will have a horizontal squint. That also you can describe. My right eye is deviated, or my left eye is deviated, or right eye is deviated inside. Inside you call esotropia, or if the eye is deviated outside, you call it as exotropia. So if there is a true paralytic horizontal squint, there will be a horizontal diplopia, there will be a horizontal squint. So that is horizontal diplopia. Now let us imagine, did he say what kind of diplopia our patient is having?
He said horizontal diplopia, ma'am.
Horizontal?
Horizontal, ma'am. Objects are next to each other.
Hmm.
And throughout all the movements, whenever he was in central position, he had this diplopia. And there was no change on any movements to either of the. When he was looking either towards the right or left, he didn't have any worsening or.
Unable to tell whether there is any plane of maximum separation.
Separation, yes, ma'am.
Okay, we'll keep it like that.
Asked, ma'am. But he said he was finding difficulty in reading the newspaper for a longer period of time. After about 10-15 minutes, he started having difficulty in reading. That is what.
Okay, so it is a horizontal diplopia in our patient. Yes, so whether it is medial rectus or lateral rectus, you are not able to decide because patient is unable to tell the plane of maximum separation and where is the false image. When we examine, we can find out what is the nature of the skin and then we will decide. Supposing our patient has told vertical diplopia, would you like to analyze how many muscles are the culprits?
There are
8 muscles.
8 muscles.
Totally, we have got 12 extraocular muscles. 4 horizontal, 8 vertical. So, if the person says my diplopia is vertical, then the culprits could be 8 muscles. That is the right superior rectus, right inferior rectus, right superior oblique, right inferior oblique, and the same group of muscles on the left side. So now let us say that my patient said that his diplopia is vertical. Then how are you going to analyze? What question first you will ask? Are the vertical diplopia one below the other, or one image is tilted and above or tilted and below? If the patient says that the diplopia is vertical but the images are oblique, then you can cut off the recti. The recti produce vertical diplopia without a tilt, whereas obliques produce vertical diplopia with a tilt. So then the 8 muscles become 4 muscles. If the patient says I have vertical diplopia but they are tilted. But like our patient, senior person, he is unable to observe that much and he is not able to tell, then we will keep the 8 muscles as possible cause. Then what you do is, next as I told you, when there is a paralytic diplopia, there will be a squint. Definitely there will be a lack of parallelism of the visual axis is needed to produce a double vision. So we'll straight away go, 8 muscles are responsible. Which muscle? Let me see. So when you go and see, one eye will be up, another eye will be down. A vertical diplopia patient will have a vertical squint. So let us imagine that my patient has got right eye up and left eye down. He has vertical diplopia and right eye is up and left eye is down. I mean, everybody is able to follow. No, any difficulty you can stop me. You see, right eye is up means right side inferior rectus.
Yes, ma'am.
Or right eye superior oblique is weak.
Yes, ma'am.
You know that the right inferior rectus is the depressor and right superior oblique is the depressor of the right eye. So if the right eye is up, on that eye, patient may have weakness of right inferior rectus or right superior oblique. And the left eye is down. Right eye is up and the left eye is down. So in the left eye, it may be left superior rectus or left inferior oblique. So by looking at the resting eye position, out of the 8 muscles we considered, we have cut off 4 muscles.
4 muscles.
Is it clear? So is it either the right inferior rectus and the right superior oblique or left superior rectus and left inferior oblique? So 8 muscles have now become 4 by looking at the resting eye position.
Yes, ma'am.
Then you have to apply the principle called, there are so many principles in eye movement, that and all we will not complicate, then you might become stressed. We will do it later. So recti act better in the abducted eye.
Yes, ma'am.
And obliques act better in the adducted eye.
Yes, ma'am.
So that is a principle of eye movement. Yes. So now let us start examining the right inferior rectus. So right inferior rectus is one of the identified suspect. No? Yes. So can right inferior rectus be the responsible muscle? Then I have to test that. I will put the eye into action in the abducted position. So abduction and depression of the right eye. Tell the patient to abduct the right eye and then depress. So right inferior rectus has been put into maximum action. Then in the left eye, which muscle is acting? Obliques act better in the adducted eye.
Yes, ma'am.
Recti act better in the abducted eye and obliques act better in the adducted eye. So when you are telling the patient to look out and look down, it is the right inferior recti. And in the left eye, which oblique? Superior oblique.
Yes, ma'am.
superior oblique is the depressor.
Yes,
Inferior oblique is the elevator. We know that. So it is a pairing muscles are right inferior rectus and the left superior rectus.
Yes.
Superior oblique.
Oblique. Yes, ma'am.
So supposing you have checked the right inferior rectus by putting the eye in the depressed abducted position. Then how are you going to check the right superior oblique? On the right eye, we thought it is either the inferior rectus or the right superior oblique.
Yes, ma'am.
Because the right eye is up.
Yes, ma'am.
The right eye is up and left eye is down.
Yes,
So it is either right inferior rectus or right superior oblique. How are you going to check the right superior oblique? Obliques act better in the adducted position.
Yes, ma'am.
Adduct.
Ask the patient
So you have to adduct the right eye.
Yes, ma'am.
For inferior rectus, we abducted the right eye.
Yes, ma'am.
Now to check the superior oblique, you have to adduct the right eye and tell the patient to look.
Left.
So the pairing muscles will be left inferior rectus and right superior oblique.
Yes, ma'am.
So supposing your patient is telling, sir, my maximum diplopia is when you put the eye in the left down and out position.
Down and out. Yes, ma'am.
So the muscles which are acting are right superior oblique and left inferior rectus.
Yes, ma'am.
So this is the plane in which there is maximum separation for my patient. So the four muscles become two now.
Yes,
It could be either the right superior oblique or the left inferior rectus.
yes, ma'am.
Then you have to write it down. If you have seen that by resting eye position, we thought in the right eye it is the right inferior rectus and the right superior oblique, or in the left eye it is the right superior rectus and the right inferior oblique. Left inferior rectus is not at all there in the picture.
Yes, ma'am.
You have to write it, then only you will understand.
Yes,
In the
ma'am.
resting eye position, we said that left inferior rectus is not involved because left eye is down. Left eye is down means left superior rectus or left inferior oblique,
Yes,
not the left inferior rectus.
Yes.
So if the patient has got maximum diplopia while looking to the left and down,
Yes, ma'am.
the culprit is only right superior oblique.
Oblique. Yes, ma'am.
Is it clear?
Yes, ma'am.
It's
Got it.
mathematics, no?
Yes, ma'am.
Did you understand?
Yes, ma'am.
So at the resting eye position, we took one example. My patient has got vertical diplopia. He does not know whether it is oblique or tilted or straight. So four culprits. Right eye up means right inferior. Right eye is going up means it is the right inferior rectus or right superior oblique.
Yes, ma'am.
Clear, no?
Yes, ma'am.
And the left eye is down.
Can we use head tilt for any of helping us to find out the
Which one, no?
head tilt? Can we ask the patient to tilt his head and
No. Head tilt will produce null position adaptation only for two muscles. One is the superior oblique, then the contralateral head tilt, and lateral rectus, it produces ipsilateral head tilt. Other muscles, there is no null position.
Okay.
Only two muscles, right lateral rectus, any lateral rectus, ipsilateral head tilt, and superior oblique, contralateral head tilt. Other muscles, there is no null position.
Okay.
So this is how you analyze a vertical diplopia. Why it is important? We are thinking it is uniocular. We don't know whether the pupil is involved or not.
Yes.
And we want to know whether it is a nerve or neuromuscular junction. So if it is at the level of the nerve, it can be polyaxial, it can be multi-axial, because many of the muscles in the fascicular course, many muscles will be involved, so patient will have maximum separation in many planes.
Yes.
But supposing patient says my maximum separation is in the plane of action of some muscles, they point to certain diseases. Like you told that there is a family history of thyroid disease.
Yes.
So thyroid ophthalmoplegia picks up which muscle? Medial rectus and inferior oblique. So each muscle involved points to certain kind of diseases. So medial rectus and inferior oblique maximum affected means it may be related to thyrotoxicosis. If it is myasthenia, the usually affected. There are exceptions always. But in myasthenia, it is the levator palpebrae superioris and superior rectus. Medial rectus and inferior oblique thyroid ophthalmoplegia. Superior rectus and levator myasthenia. Lateral rectus is inclusion body myositis, loya, parasitic myositis. No? All those conditions involve the lateral rectus. So that is the use. In our patient, you said it is horizontal. He is not able to tell which is the plane of maximum separation. So our patient is already having a drooping of eyelid. So knowing whether it is a lateral rectus or medial rectus will help us to know whether it is a nerve or a muscle plane. If it is levator and lateral rectus, two different nerves are supplying.
Yes, ma'am.
So it will favor a muscle involvement. Supposing it is a levator and medial rectus, it will help us from the history only. Maybe it is a evolving third nerve. Because third nerve supplies the medial rectus, third nerve supplies the levator. It is important for us, but unfortunately our patient is a senior person and he is unable to tell whether the diplopia is having any plane of maximum separation. So we will keep it like that. We will do it when we are examining. But if it is right levator and right medial rectus, it will help us to still keep the differential diagnosis of a fascicular third nerve. But if it is right levator and right lateral rectus, we will think multiple muscles are getting mixed up. It may be a neuromuscular junction disease. That becomes the first diagnosis. Okay, when that information is not there, we have to examine and find out. So that is double vision. Then for interest sake, I will tell one question.
Yes, ma'am.
There is something called Mendel diplopia.
Okay, ma'am.
Mendel diplopia, heard of that?
No, ma'am, not heard of.
Mendel diplopia is, you see, none of us has seen our face, no?
No.
We see other people's faces only. We don't know our face. Our face we have always seen in the mirror only. We have seen our reflected faces and people tell us that this is your reflection. Then we think this is my face. No.
Okay.
So it is said that each one of us have got a body schema based on the default mode network of body representation. And we have got another image which is constituted by reflected images which we have been told belongs to you and you superimpose them. So that is called physiological Mendel diplopia. That is the way you recognize your reflections in the mirror as belonging to you. So we have got a body schema based image and we have a reflection based image. So that is physiological diplopia, Mendel diplopia. When that is damaged, we get a mirror image agnosias and all. That's another topic by itself that will not go into. So now my patient has got an asymmetrical ptosis. It is partial ptosis. It is fluctuating ptosis. He is having some extraocular muscles that belongs to one of the 4 horizontal muscles which we will analyze. Next symptom you told he is having speech problem.
This patient also said like on washing his face with cold water or doing continuous activity, he used to get this diplopia used to worsen.
Definitely there is a feature of fatigability and lower temperature is favoring him. Yes. So those all points are favoring neuromuscular junction disease. Yes. That's okay. Those points are points in favor of fluctuation. Fatigability indicates neuromuscular junction disease. Yes. We'll come to that. In that fatigability, any weak muscle will become tired after, even if it is third nerve, it will worsen after fixing on that.
Okay.
Fixing on. So we call it as a pathological fatigability. Even if you are tired after a night duty, don't you feel your eyes come down? No. Yes. So that is how do you differentiate? Everybody says I am fatigued. No. Everybody will, many people tell us I am fatigued. So how to differentiate physiological fatigue from pathological fatigue? That is why we measure the palpebral fissure. You see, pathological fatigability is demonstrable. Physiological fatigability is subjective. All of us wash our face with cold water when you are studying for exam. You feel fresh. We are not suffering from myasthenia. No.
Yes.
So always cold water does not indicate myasthenia. Everybody becomes fresh. So whether it is physiological or pathological, after some rest, after cold, all of us feel better. So to know what is pathological, subjective versus objective.
Okay.
So that subjective aggravation or subjective improvement, is it objective also? So you can tell the patient, you take a photograph of your eye before cold water and after cold water and bring it. If it is subjective, that becomes a soft sign. Subjectively, cold water produces freshness for everyone. But objectively, you find that the drooped eye has opened up. Then it is a pathological fatigability. So pathological fatigability is the only one which will tell you it is really neuromuscular junction. Physiologically feeling fresh does not mean anything. So that point also you should ask from the patient. If he is able to provide us, it is a point closer to neuromuscular junction. If he is unable to provide us, we will keep it like that and we will examine. Okay. Go to the next symptom.
Next symptom was he had slurring of speech, ma'am. That
Yes.
started after about 20 days, since 20 days. So after 10 to 15 days later, he started developing slurring of speech. Slurring of speech is such that he was able to talk properly, is able to complete sentences. But however, on continuously talking for about 5 to 10 minutes, he starts getting the slurring of speech. He notices the slurring of speech with the change in the nature of the voice also, ma'am. So this is
So what happened to the voice?
Like he feels that the pitch has changed in the voice, ma'am. He is unable to say whether it is low or high, but he feels the quality of the voice is changed after speaking for about 5 minutes.
When you are seriously thinking of a fatigability in speech also, no?
Yes, ma'am.
When you are continuously talking, it is coming down. What specific question you will ask? In other words, I think last class we defined speech also.
Yes,
Would you like to recapitulate that, ma'am? How do you define speech?
Ma'am, speech is defined as
Language is ability of the individual to convert thoughts into comprehensible modes of communication. So language has got reading, hearing, speaking, writing, repeating. So 5 components are there in language. Converting thoughts into comprehensible modes of communication is language. Whereas speech is converting language into audible sounds. So speech has got only one component. Language is already there. So when you say my patient has got a speech problem, I will take it that all other components are all right. He can read, he can comprehend, he can write, he can repeat, but only the sounds are altered. So ability of the individual to convert language into audible sounds is affected, means it is speech.
Yes, ma'am.
So now we know it is speech, other aspects are normal in this patient. So just like a revision sake, would you like to tell me the type of speech disorders? Then we will know what our patient is having.
Either it can be a spastic dysarthria or so that will be a UMN type, or it can be cerebellar type wherein there's staccato, forceful and there's a gap between the words, ma'am. Then it can be either the lower motor wherein either there is a particular syllables are lost, whether the movements at the lip like pa, such letters are lost. Predominant selectivity for either the labials, linguals or buccal involvement, the specific words that are there lost.
So speech disorders are classified into hyperkinetic and hypokinetic. So speech disorders are classified into, as you told, spastic, flaccid, dyskinetic, ataxic, cortical. 5 types. Spastic, flaccid, ataxic, dyskinetic and cortical. So spastic is seen in upper motor neuron disease, pseudobulbar palsy, M and D, those conditions. So how is the spastic speech? So spastic speech will be strained. Patient will try to squeeze out the words. Patient will be straining in front of you. So it looks like patient is straining to bring out the words.
Yes.
Because of that, syllables will run into one another. So there is a phenomenon called lisping. Is sound will come. That's called lisping. So spastic speech is stressful speech. Patient strains too much. Syllables run into one another, and there is an element of lisping. Effortful, lot of effort is put, and it looks like patient is squeezing out the words. That is spastic speech. Next, we will come to ataxic speech, which you told. Ataxic speech, you have got staccato and scanning.
Okay.
Scanning speech is syllables are split into one another.
Yes.
So we used to commonly use Chakravarti Rajagopalachari, very long name, no? So a person is scanning speech will tell Chakravati. That is scanning speech.
Yes.
The one name is split into its syllables.
Yes.
That is scanning. What is staccato speech? Explosive character and undue pressure where you don't have to press. So Chakravarti Rajagopal, no? So you are producing a stress on a site where you don't have to. So that is a staccato speech. So ataxy can be scanning or staccato. Both are cerebellar only.
Yes, ma'am.
Next is dyskinetic.
Yes, ma'am.
Dyskinetic is extrapyramidal disorders, basal ganglia.
Yes, ma'am.
And dyskinetic speech disorder is either hyperkinetic or hypokinetic.
Yes, ma'am.
Hypokinetic is the classical Parkinsonian speech. What happens? As he is going on talking, it will show some kind of thing which resembles fatigability.
Yeah.
The voice volume goes on sinking down. So when he starts the conversation, he is loud, and as he keeps on communicating, his voice goes down. Then how do you differentiate it from the bulbar muscle involvement in myasthenia? So that is a thing which closely mimics. Hypokinetic speech disorder is progressive decrease in the voice volume as communication goes on.
Okay.
So how will you differentiate it from myasthenia? There, it is a manifestation of bradykinesia, slowness. We do this, no? We do this kind of movement, and when the patient's amplitude and frequency comes down, we say it is bradykinesia. Same bradykinesia is manifest in communication, that is progressive decrease in the voice volume in extrapyramidal. Whereas in myasthenia, it is the palatal muscles which fatigue. So as the patient keeps on talking, instead of voice volume sinking, he develops a nasal tongue. So in this patient, when he told this symptom, he is an old man, he can have Parkinsonism also, nothing prevents him from getting it. So he'll ask, when you keep on speaking, you said your voice changes. What happens, sir? Do you get a nasal tongue? So that is very much possible in this patient. So that is how myasthenia and hypokinetic speech of extrapyramidal disorder is deep. Hypokinetic disorder speech, there is no change in the quality. Only the volume comes down, voice volume comes down.
Okay.
Whereas in palatal muscle weakness, character changes to nasal tongue. Then it is LM. That is hypokinetic. Then hyperkinetic and the dyskinetic will be tremor, chorea, voice tremor. You might have seen senior people having a shaky communication. That is voice tremor. That's a hyperkinetic one. Or if you have a chorea, what happens? Every time the tongue goes into a choreic movement, there will be an unwarranted stop. When a choreic movement comes, patient will stop talking. So unwarranted, unexpected, sudden stops, and you look at the tongue is having a movement. That is a choreic. So voice tremor is one hyperkinetic, chorea is one hyperkinetic, and you can have tongue tremor, trombone tongue. I am sure you might have heard of trombone tongue, which you get in Wilson's disease,
Yes.
neurodegeneration with brain iron accumulation, neurosyphilis, no?
Yes, ma'am.
There, the linguals will be trembling. Unlike the voice tremor, the whole voice shakes. It is very common in senior people. But the trombone tongue is only for linguals.
Okay.
The words which need the tongue, L, D, T, they need the use of the tongue. So when the patient speaks these words which contain L, D or T, there is shakiness. That means it is a tongue tremor. So hyperkinetic is seen in voice tremor, tongue tremor and chorea. Hypokinetic is Parkinsonism, where bradykinesia manifests as progressive decrease in the voice volume. Then we will come to flaccid dysarthria. Flaccid is LMN. What are all the LMN structures? It is the muscles of the lips, muscles of the palate, muscles of the tongue, and we generally include the teeth also.
Okay.
When the patient removes all his teeth and wants to get a danger, then also there is a change in the speech. That is also included under flaccid for convenience. So labials, dentals, linguals, gutturals. So flaccid speech could be for labials, linguals, dentals and gutturals. So when the patient speaks, as you correctly told, if there is a problem with P or B, papadam, baby, no? The letters P and B are labials. Then you know your patient's orbicularis oris is paralyzed. Supposing it is a tongue, it will be L, D, no? So whenever he is speaking Lily, he slurred. Otherwise he is all right. Then you know maybe the hypoglossal nerve or the tongue muscles are getting affected. Then dentals are D and T. Dog, no? Top. So dentals are D and T. And gutturals are NG, GG. So singing, bringing, egg, hugging, no? That NG, GG words alone, there is a problem. That means palatal muscle. So flaccid dysarthria could be for labials, it could be for linguals, it could be for gutturals, or convenience sake, dentals are also classified under flaccid. So apparently, I think your patient has got a labial type, and probably the gutturals. No, he is unable to raise the voice, and the voice alters. You told, but the character is not able to tell. So maybe it is labials and gutturals. Yes. We will get a sample of the speech and then decide what it is. No? Yes. So yes, and then there is a cortical dysarthria. What is cortical dysarthria? Is a lulling kind of speech. It can be in the young children, very common, mentally subnormal children. They utter the words, meaning, grammar, everything is all right. But a childish character is there. Okay. That is one cortical dysarthria and mental subnormality. Or you can get a cortical dysarthria when the Broca's area is suffering an watershed infarction and gets separated from the rest of the brain. Okay. That is a motor association area, and motor area of speech gets separated. Then there is an altered character to the speech that is called cortical dysarthria. So cortical dysarthria is a lulling speech of mentally subnormal children, or in older people when the Broca's area is disconnected from the frontal lobe, some alteration in the speech character is happening. Yes. So now we found that my patient has got a asymmetrical ptosis. He has got an extraocular muscle involvement, one of the horizontal muscle. And second, we think that he has got probably a flaccid dysarthria. Is it the labial or the gutturals? We don't know. Probably both are involved. Then next symptom we have to see. He has got a swallowing problem. No?
Yes, ma'am.
Would you like to analyze, ma'am, swallowing?
Yes, ma'am. Swallowing, it is firstly, he says.
How will you describe a person who complains of swallowing problem? In this context, so many things are already involved. Yes, so to take this context and describe in detail, so we get a localization.
Yes, ma'am. So because there is no pain, so it is not a local cause. So adenophagia is ruled out. So because it is now dysphagia, ma'am. So dysphagia, it can be since we have the possibility of a flaccid dysarthria in the background, ma'am. So It can be because of the involvement of the nerves, ma'am. So the seventh nerve, the ninth nerve, or the 12th nerve. So that can cause because of neuromuscular weakness. So the swallowing, it can be either because of the weakness or some mass. So either luminal or extraluminal compression, ma'am. So here it looks like there is difficulty to both
So first,
solid.
what you have to determine, you are telling whether it is obstructive or non-obstructive. No,
Yes.
luminal or extraluminal. You wanted to rule out whether there is any obstruction or non-obstruction. That's okay. But first of all, we have to analyze the symptom. In this case, it may be straightforward.
Yes,
but other cases, it will help you. So swallowing involves LMN and UMN pathways.
Okay.
I'm sure you know that. In the LMN, what are the phases which you study in Ganong's physiology? Or we study the Sherrington's cat. No? You have got a oral phase, you have got a pharyngeal phase, you have got an esophageal phase.
Yes,
so 3 phases. So which phase is affected?
Here
that we can easily elicit by history. Oral phase involves chewing first. When you put the food into the mouth, you are going to chew. When you are chewing, is the patient able to approximate the upper jaw and the lower jaw properly? Is he able to bite? Or is the food particles get loose and the tooth are not getting approximated, means it is the pterygoids. You see, medial pterygoids close, lateral pterygoid open, and medial pterygoid and lateral pterygoid of one side moves the jaw to the opposite side. So these are the things which happen during chewing. You close, you open, and you move the jaw to the side to side. So side to side movement is one medial pterygoid and one lateral pterygoid will move the jaw to the opposite side. Both medial pterygoid will close. Both lateral pterygoid will open. So is there any difficulty in this phase? Then you know it is the pterygoids helped by masseter and temporalis. So if the patient says, no, I am able to chew, there is no difficulty in biting, I can move the jaw side to side, then these muscles in the oral phase are not affected. So is the chewing affected or not? That's the first question. If the chewing is not affected, in the oral phase, chewing muscles are not involved. Next, in the oral phase, the chewed food goes and lies in between the teeth and the cheek. That is the gutters. We tell the food will lie in the gutter. So the food lies in the gutter and the food is brought to the floor of the mouth by buccinator. So that's a facial muscle. So buccinator is weak, means he has chewed the food properly, but the food, many patients might, with the facial palsy, they will tell that they use their fingers to bring the food to the floor of the mouth.
Yes,
so if the patient says, I am chewing all right, but my food has to be pushed to the floor of the mouth with a finger mechanically, that means the buccinator is weak. That is a second group of muscles, the facial muscles in the oral phase. And if the orbicularis oris is weak, we are strongly suspecting he has got some problem while speaking. No, orbicularis oris is weak, means the food will be brought from the gutters to the floor of the mouth, but the food will leak. When he is trying to put it backwards, the orbicularis oculi will not close properly, so the food will leak through the sides. So next question, is your food leaking through the sides of the mouth? So the patient says no. Then the next phase, in the next structure involved in the oral phase is the tongue. So the food has now been brought to the floor of the mouth. It has not leaked out, and now the food is lying on the top of the tongue. The tongue, the intrinsic muscles of the tongue will roll and push the food backwards. So is that happening? No, normally, then the tongue is also all right. You see, so you have to ask, is it the oral phase? Chewing is all right or not? Food is brought from the gutters to the floor of the mouth. Is it leaking out? And can you push it back? If all this is all right, oral phase is all right. So next is the pharyngeal phase. Pharyngeal phase, you have got the oropharynx and the nasopharynx. In the pharyngeal phase, the nasopharynx has to be closed and the oropharynx has to be kept open. that we call it as swallowing apnea. During swallowing, there is apnea, respiratory arrest. And you exhale before swallowing and after swallowing, so that nothing goes into the respiratory passage. So if the patient says, when I am trying to swallow, my food is coming through the nose, or I am trying to cough, or I get choked, that is what your patient is having. You told that your patient feels choked.
Yes,
That means the food is, the nasopharynx is not properly closed. That means the epiglottic muscles, the palatal muscles are probably weak. They are not closing the nasopharynx properly, so he feels choked. That is a esophageal phase, pharyngeal phase. Third is the esophageal phase. My patient is telling, I'm able to swallow, I'm not coughing, everything is going inside. But after that, it becomes stuck. It may be polymyositis, scleroderma, esophageal strictures, pressed by esophagus, tumors of the esophagus, all of them. So you told me obstructive. The obstructive comes in the third phase, the esophageal phase. It doesn't come in the oral phase or the pharyngeal phase. So if the patient's oral phase and pharyngeal phase is all right only, you have to think of obstructive cause as a differential diagnosis. In the esophageal phase, the commonest cause is pressed by esophagus. Older people, the motility of the esophagus is not sinusoidal. So they will feel stuck, they will choke, they will cough. They will tell that the each food, they will add a little water and push it down. That is called pressed by esophagus. So oral phase all right, pharyngeal phase all right. When it reaches the esophageal phase, they need little more water to push it down. That is esophageal phase. But you told mechanical obstruction. That is a commonly asked question in the MD examination. I know that. But first you have to characterize the phase. If it is esophageal phase, then you talk about obstructive. Now tell me, how are you going to differentiate the obstructive from pressed by esophagus or other causes in the esophageal phase, obstructive and non-obstructive, achalasia cardia, no? That is a common question.
That will ask whether it is predominantly affecting both solids or liquids, or whether it is which is predominant, ma'am.
So which will be predominant in obstructive?
Solids will be affected
Yes.
more, ma'am.
Because where there is very little space, and solids will not be able to squeeze themselves. So if your patient has got an esophageal phase dysphagia and it is for solids, then it means there is a mechanical obstruction. Maybe my patient has got a CA esophagus with some paraneoplastic syndrome. That will become a question. Whereas if it is achalasia cardia, liquids are more difficult than solids because liquids need fine coordination. That fine coordination is not there when the achalasia cardia is there. But if it is a neuroparalytic, generally both are weak. Because there is neither quick coordination nor powerful coordination when there is a neuroparalysis, but something can come little earlier than. But persistently, only liquid or only solid will help us to differentiate. But in neuroparalytic, it is a semi-solid that is easy. Because semi-solids can drag themselves. They neither need powerful coordination, they nor need quick coordination. So semi-solids just manipulate themselves and go. So if the patient says, I am only able to make it as a porridge, I put bread into the milk and I take it, that is okay. Whereas both liquids and solids are difficult. We tell liquids need quick coordination, quick, fine coordination. Solids need powerful, coarse coordination. In neuroparalysis, both are not there. So semi-solids are generally easy, even though patient might experience mild, it is not 1:1.
Yes,
but you have to tell the history like this. Our patient may be clear-cut, but you should know there is a oral phase, there is a pharyngeal phase, esophageal phase, and which phase you have to tell.
Yes,
Then you have got, because you said it is a cranial nerve.
Yes, ma'am.
Can you tell me in the brainstem, the upper motor neuron mechanisms in swallowing? For swallowing, there is a motor component. Respiration has to be stopped. And there is a taste. An unwanted food should be vomited. No.
Yes, ma'am.
When you swallow, if somebody is giving poison and you sense it is poison, you vomit. No. So the motor nuclei are there in the brainstem from the pons and the medulla. All the motor nuclei, the fifth, the third, the fifth, the 12th, 7th, all are in the pons and the medulla.
Yes, ma'am.
That is one brainstem center for swallowing. Motor center. Second, taste. Anterior 2/3 and posterior 2/3 of the tongue. Anterior 2/3 through the 7th nerve. Posterior 2/3 through the glossopharyngeal nerve. And the palate from the 10th nerve. They enter in the nucleus of the tractus solitarius, which is in the medulla and the pons. So that is the taste pathway. So motor pathway in the motor cranial nerve nuclei in the pons and the medulla. And the taste is in the nucleus of the tractus solitarius.
Yes,
And next to that, in the floor of the fourth ventricle, you have got the vomiting center.
Yes, ma'am.
That is the area postrema and the chemoreceptor trigger zone.
Yes, ma'am.
And you have also the respiratory center in the pontomedullary region. So these things all go. The motor centers are there in the motor cranial nuclei. Taste is in the nucleus of the tractus solitarius. And the respiratory center is there. And the vomiting center is there. So the taste is carried to the insula.
Okay.
Motor activity is carried to the basal ganglia and the motor cortex. No? And the respiratory center is interacting there. And the vomiting center is also interacting. So taste is carried. The taste is sensed. And you feel that the taste is comfortable. Then you swallow. Nasopharynx is closed. Oropharynx is opened. Respiration is suppressed, vomiting is suppressed by the higher cortical influence, and you swallow. Supposing it appears like a poison. Insular area says this is poison. So what happens? Immediately the vomiting center is activated. And the motor schema is formed in such a way that you regurgitate out, activate the area postrema and the chemoreceptor trigger zone. And so this is the brainstem integrator. It is called brainstem integrator. The motor cranial nucleus, nucleus of the tractus solitarius, area postrema, chemoreceptor trigger zone, and the respiratory center together are called the brainstem integrator for swallowing. Then you have the cortex. In the cortex, you have got the motor cortex and the prefrontal area. It is not always reflex. Many times we swallow voluntarily. And once the food reaches the pharynx only, it is reflex. Till then, when we are not hungry also, sometimes we eat. As a social obligation, we eat. That is all formed by the prefrontal region. Voluntary command to the motor area, and then comes the motor nuclei. Okay, you swallow, this is a friend, you have to take tea in his house. No? That is the prefrontal cortex. Then you have got the inferior frontal cortex, where you have got the mouth and other muscles are located. Insular region for taste. And all this comes down and acts on the brainstem center. So these are the higher control of swallowing. Brainstem integrator and motor control from the inferior precentral area, and voluntary swallowing from the prefrontal region, and taste from the insular region. These information come and converge on the brainstem and facilitate in the upper motor neuron to vomit or to swallow. So in our patient, you told that he feels choked. So you will tell that my patient has got a pharyngeal phase swallowing defect. It is not in the esophageal phase, so I am not considering any mechanical obstruction. So it is a pharyngeal phase swallowing. So your patient has got an asymmetrical drooping of the eyelid. He has got a horizontal diplopia. He has got a labial and guttural based dysarthria, flaccid dysarthria, and he is having a pharyngeal phase swallowing defect. So what are how will you combine these symptoms? Some questions somebody put that we'll answer at the end. So,
based on
how are you going to summarize these findings? One, it is all pure motor.
Pure motor, ma'am.
Yes, patient did not have any sensory anywhere. Everything is motor. Even the bulbar muscles, it is not at all. The patient is appreciating sensation, hot, cold, taste. Only swallowing is affected. So it is purely motor. One. Second, it is asymmetrical.
Yes, ma'am.
Probably LM. It looked like. So purely motor, asymmetrical LM. So that becomes the different information from the history. So pure motor syndromes involving these structures could be muscle disease, myoneural junction disease, or nerve disease. Anything it can. So generally muscle diseases are symmetrical.
Yes, ma'am.
So commonest muscle disease is oculopharyngeal myopathy, which is a close differential diagnosis. It can happen late also.
Yes, ma'am.
Ocular muscles are involved, pharyngeal muscles are involved. So it can be oculopharyngeal myopathy.
Yes, ma'am.
Second, but what are the points we will come to?
Yes,
second is neuromuscular junction. Second, you have got MND, motor neuron disease. Old age, pure motor syndrome, it can be motor neuron disease. Then cranial nerves, we will keep it as the last possibility because there is no sensory, even though bulbar is involved, the pharyngeal sensations are all right.
Yes, ma'am.
Apparently. So nerve is less likely. So in the order of priority, is it a neuromuscular junction? Is it an oculopharyngeal myopathy? Is it a motor neuron disease? Or is it a cranial nerve? These are the questions. So now only we will differentiate, then we will go to examine. Okay. So many times oculopharyngeal myopathies and neuromuscular junction disorders are miscommunicated between each other. Treatment is different. So how will you differentiate a muscle from neuromuscular junction at this point?
Muscle disorder usually that is symmetrical. There is no episodic weaknesses are usually not present, ma'am.
Yes.
Like diurnal variation.
So one is you told symmetry in muscle disease. Neuromuscular junction is generally not symmetrical. Second point you said muscle disease is persistent. Whereas neuromuscular junction is fluctuating.
Yes,
fluctuations can happen. And third point, fatigability is there in neuromuscular junction. Objective fatigability. That is speech becoming in the nasal tang or drooping becoming narrower palpebral fissure. Not just the patient says, I am feeling tired, let me rest. No. You feel that the speech character changes in the nasal tang and the palpebral fissure becomes narrower. That is neuromuscular junction. So these are the three cardinal important points in the history: symmetry, then fatigability, and fluctuations. Neuromuscular junction, it happens. When muscle disease, it doesn't happen. When you examine, what are the things you will look for keeping these two differential diagnoses? Both do not involve the pupil. If the pupil is involved, it goes for the nerves. So both of them resemble each other in the sense that they do not involve the pupil. What other things you will examine? When you look at eye movements, very, very important. It is very life-saving in very sick patients. You see, you can never elicit a saccadic or the fast eye movement in a muscle disease. Even though patient may be slowly dragging the eye to the lateral side, there is no fast eye movement, always slow movement only. Whereas in neuromuscular junction, it is a petrol failure, energy failure. So the available range, if you tell him to move fast, he can. So the movement may be only 5 degrees, but that 5 degrees he can generate a fast movement. This will be very useful in bedridden patients. You cannot take them to the EMG lab. He may have heart disease. You cannot do a neostigmine or hydrophonian test. So if you generate a saccade within the available range, it is neuromuscular junction. It means the muscle is not paralyzed. It is only the energy that is filled, and the available energy is used to generate a fast movement. Whereas muscle disease, you can never generate a fast movement. Second point, all of you know that you demonstrate a curtain sign. In neuromuscular junction, you tell the patient to fix for at least maximum period is 5 minutes. Even the minimum weakness is there, but at the end of 5 minutes, you are expecting a drooping. So curtain sign is fixed at the target. The maximum duration is 5 minutes. Within 5 minutes, a drooping comes means it is fatigability. That is called curtain sign. Opposite of that is called yawning sign or peep sign.
Peak sign. Yes.
Peep sign or yawning sign, you tell the patient to tightly close the eye and the eye will open.
Yes.
After some time, the eye opens. That is peep sign. Then you have got plus minus sign. You close one eye, the opposite eye opens. And close the other eye, this eye opens. Yes. That is also a neuromuscular junction. Then Cogon's eyelid twist sign. Yes. Twitch sign. That is, you tell the patient to slowly follow a finger which you are keeping below. Yes, but what you are telling the patient, you have to follow my finger in the speed of my moving finger. Yes, that means what? You have to hold back. Okay. So you are telling the patient to open the eye. But it is like somebody is pulling a bullock cart, let us imagine. One person is pulling from front. One person is supporting from behind. Who will suffer more? Even though apparently it is pulling forward, the one who is behind will suffer more. Because he has to give maximum force to prevent it back. Similarly, when you tell, move your finger in the speed of my finger, move your eye in the speed of my finger from below, he cannot simply open. He has to hold back and wait for the finger to move. So it is a holding back muscle, which is like the person who is behind the cart. So the holding back muscle is the orbicularis oculi. The lifting muscle is the levator. So when you lift in the speed of your moving finger, the holding back muscle is working more. The lifting eye muscle is working less. So you just slowly move. Halfway through, the orbicularis oculi is holding back. So it loses energy earlier than the levator. So midway through, the eye will open and peep at that is called Cogon's eyelid twitch sign. Very, very typical of myasthenia. Not present in all cases, but if it is present, it is very useful. Slowly you have to move. Midway, eye will open. Quickly it will open. That is Cogon's eyelid twitch sign. Then, of course, you know, pseudo-MLF. Because of the asymmetry of the extraocular muscles, one eye may show adduction failure and another eye may show muscle peritic nystagmus. You may think it is pseudo-MLF. You may think it is MLF. That is pseudo-MLF. No? Then, as you said, the cold water, the ice pack, you apply and show a demonstrable improvement in the eye movement. Then, of course, the neurostigmine test. Whereas in myopathy, it is symmetrical. None of these signs are there. You can never generate saccades, even though the eye movement may be slow and full. You can never generate saccades, and people are not involved. This is how to differentiate oculopharyngeal myopathy from myasthenia. Why they are mistaken is when you do repetitive nerve stimulation, if there is a typical case of myasthenia and the fatigability is more than 10%, you can call it as myasthenia. So more than 10% fatigability can sometimes happen in oculopharyngeal myopathy. And the senior neurologist or whoever is seeing the patient has not seen the patient. So somebody is telling it is myasthenia and you have shown that more than 10% decrement. So you will diagnose myasthenia and put the patient on cholinergic drugs. A senior person develop cardiac arrhythmia and die. He may be suffering from oculopharyngeal myopathy. And by iatrogenic, this has happened in doctors. It has happened because of the more than 10% decrement is taken as favoring myasthenia, not examined properly. No? And the only thing which helps when the patient comes with atrial fibrillation, ventricular tachycardia, and this was one pediatrician I have seen. She was a lady, she had oculopharyngeal myopathy, and she kept on increasing the dose because she was afraid of, she felt bad to again and again see doctors until I'm not improving. And she developed cardiac arrhythmia, and she developed acute tubular necrosis due to severe hypotension. And she went into peritoneal dialysis, and she died of this iatrogenic complication. Instead, she would have lived a little more longer with the muscle weakness. She could have used other assisted mechanisms to swallow. So this is very dangerous. If you have seen one case also. Then at the bedside, the only thing which helped was she did not have any succor. Even within the hours, she was very sick with a cardiac arrhythmia and hypotension and acute tubular necrosis. So somebody is worried whether they can withdraw the anti-myasthenic drugs or continue when arrhythmia is going on. You see. So only point that helped that person, I saw her when she was very sick. She had no succor. I said it is not myasthenia, it is myopathy. So withdraw the drugs. The drugs were doing harm, but still are they indicated for some other cause? So these simple findings will be helpful in one case in your life also, it's very useful. So this is how you differentiate. And motor neuron disease, it will never produce ptosis. See, motor neuron disease can produce bulbar weakness, it can produce LMN, it can produce UMN, tongue can be gone, but ptosis doesn't happen. Ptosis is generally spared in motor neuron disease, so you think it is less likely. And cranial nerves, we don't know. When you examine, people are involved or you find sensation, you may have to think of cranial nerves. So closed DD becomes myopathy versus myasthenia. And now go next.
Yes,
examine. Somebody asked lateral medullary syndrome.
Yes,
what question, ma'am?
Yes, ma'am. 1 second, ma'am. Someone had asked
swallowing difficulty happens in lateral medullary syndrome. Huh?
Can we get dysarthria in lateral medullary syndrome? If yes, what type?
Lateral medullary syndrome is posterior inferior cerebellar artery, no?
Yes, ma'am.
So you will get a cerebellar type of dysarthria.
Yes,
you can get a dysarthria, very much uncommon, but you can get, if you get it is a cerebellar type of dysarthria commonly. Second, you can get a palatal weakness. So sometimes you can get a nasal tang also.
Yes, ma'am.
So lateral medullary syndrome, two types of speech can happen, but very much less common. Because it is a neocerebellum that involves a dysarthria, whereas in the lateral medullary syndrome, there is not much involvement of the neocerebellum. But it can happen. Mild degree of cerebellar type of dysarthria or palatal type of speech can happen.
Yes.
Any other question, ma'am?
They asked if we can repeat 4 Ds of vesicular involvement. Diplopia. 4 Ds of vesicular third nerve involvement.
Vesicular third nerve involvement. Vesicular third nerve is after the third nerve has come out from the nucleus. At the nuclear level, that Warwick's pattern is there. So I said all those points. Bilateral ptosis, pure pupil, without eye movement or individual eye movement, pseudoparanoid syndrome. If ptosis is there, it is bilateral. Vesicular means it is a 4D.
4D, yes.
Diplopia, divergent skinned, drooping of eyelid and dilated pupil. All things go together because in the vesicular level, everything is together. The 4 Ds are coming at the vesicular level.
Yes, ma'am.
Weber syndrome, intraaxial vesicular. So vesicular can be intraaxial or extraaxial. Intraaxial vesicular is the Weber syndrome and all. Vascular, demyelinating, syringobulbous, tumors of the brainstem, they are intraaxial vesicular. Whereas cysternally supraclinoid aneurysm of the internal carotid artery or meningitis, that is in the cysternal space, then the brainstem features will not be there. Like that.
Yes. We'll go to the examination. Coming to the clinical examination.
Tell me, ma'am.
This was an elderly right-handed gentleman with no background comorbidities. He presented with he was an elderly male, conscious, cooperative, lying supine on the bed, well oriented to time, place, and person. BP was 140 by 80 millimeter of mercury in both right and left arm supine posture, with pulse being normal, 78 beats per minute, regular, normal in volume, character, and the vessel wall was not thickened. Peripheral pulses were well felt. Respiratory rate was 18 cycles per minute, abdominothoracic in nature. Due to examination, there was no pallor-icterus cyanosis clubbing, lymphadenopathy or edema. There are no neurocutaneous markers. There is no facial asymmetry or any wasting of temporalis muscle. Coming to the nervous system examination, higher mental functions. Patient is conscious.
No wasting. What is the importance, ma'am?
Ma'am,
You said
it can
specifically
be
no wasting.
myotonic dystrophy can also have such presentations, ma'am.
More than that, we are already considering motor neuron disease.
Yes,
We are considering myopathies.
myopathy.
They all will produce wasting.
Wasting, yes.
So absence of wasting is a point in favor of neuromuscular junction.
Yes.
Neuromuscular junction disease wasting happens only in some rare types of congenital myasthenias, not in acquired myasthenia. Acquired myasthenia, if it is untreated for several years and severe diffuse atrophy like that, it can happen. But absence of wasting is a point in favor of neuromuscular junction, and it is not common with the motor neuron disease or myopathy.
Okay, ma'am. Coming to higher mental functions, patient was conscious, alert, cooperative, well-oriented to time, place, and person. Memory, immediate, recent, and remote memory was intact. Language was normal, was preserved. Speech, dysarthria, flaccid dysarthria, which was episodic, which involved labial, linguals, and gutturals. There was
Linguals were also involved, huh?
Yes, ma'am. All were involved, ma'am.
It is relatively less common.
Okay.
Now, linguals are involved in what kind of muscle disease? Linguals can be involved in bulbar type of MND.
Yes, ma'am.
On myopathies do not involve,
Yes,
but rarely neuromuscular junction disease can involve the linguals. That is anti-musk. You heard of anti-musk antibody?
Yes, ma'am.
Not acetylcholine receptor, classical acetylcholine receptor antibody. Anti-musk antibody can produce linguals, but otherwise it is less common. Okay.
There was no nasal twang or any regurgitation that was noted.
It was not there.
It was not there, ma'am.
Okay. Maybe when you examined, he was in the on phase.
On phase, yes.
Maybe. Yes.
Probably, ma'am.
Because already he had swallowing difficulties, he was choking. So that is expected. But that fluctuating phase, you might have seen him.
Yes,
okay.
Lobar functions were normal, ma'am. Coming to cranial nerve examination, mainly the second cranial nerve. Counting finger was reduced at 4 meters. Counting finger was put at 4 meters. Superior visual field was reduced. Ptosis was noted, ma'am. That image is there. I'll just show that image after this.
Pupil is covered or not covered?
Ma'am?
Pupil is covered or not covered?
Pupil is not covered, ma'am. Pupil was not covered.
It's a partial ptosis.
Partial ptosis, ma'am. Pupils were round, reactive, and regular, 4 millimeter in size. Color vision was normal. A senile immature cataract was also noted. Fundal glow was present on fundus examination. Bilaterally, ma'am. Coming to third, fourth, and sixth cranial examination, there was pupillary reflexes that were present and equal, but there was complete external ophthalmoplegia that was present bilaterally. But however, patient said he had this horizontal diplopia in primary gaze with no worsening on asking the patient to look to either all the 8 cardinal directions of gaze, ma'am. Coming to the fifth nerve examination, the fifth nerve sensory motor and was intact. Jaw jerk was absent.
He has horizontal diplopia.
He has horizontal diplopia, ma'am.
What does that indicate? You said all the eye muscle movements are paralyzed. So it's a frozen eye with relatively better preserved horizontal muscles, I think. Because when all other muscles are completely paralyzed, there will be no diplopia. Because there will be no lack of parallelism of the visual axis. If all, that is why it doesn't happen in myopathy. In myopathy, there is uniform involvement of all muscles. So the relatively sparing of the horizontal muscle is what is causing the horizontal diplopia in this case. Because that is again favoring myasthenia. As I told you, it is levator and the superior recti, the vertical muscles. So vertical muscles are probably severely involved and symmetrically involved.
Yes, ma'am.
So they are not producing a diplopia. Horizontal muscles are relatively better preserved and they are asymmetrically involved. Therefore, they are producing a horizontal diplopia.
Yes, ma'am.
Because the frozen eyes, in the frozen eye, only the preserved muscles with an asymmetry between both eyeballs can produce a lack of parallelism in the visual axis.
Yes, ma'am.
So that is the only one which is horizontal muscle is making the disease asymmetrical in the intraocular muscles, extraocular muscles.
Yes, ma'am.
So you have to say why horizontal diplopia, because vertical muscles are completely frozen and horizontal muscles are partially involved. So there is horizontal diplopia.
Yes, coming to the 7th now, there was weakness of the orbicularis, oris, oculi and buccinators that was noted. 8th nerve was normal. Coming to the 9th and 10th cranial nerve, palatal movements were preserved, but the gag reflex was absent bilaterally. Palatal movements were equal and present both the sides.
Absent gag.
Absent gag bilaterally, ma'am.
Does he feel the sensation?
He feels the sensation, ma'am, but there is no gag that was present, ma'am.
Does he have pawn chewing or anything like that?
He didn't give any history like that, ma'am. Oral cavity also was normal.
Does he have any tendency to swallow, vomit or anything when you touch the palate? It is there?
Yes, ma'am, it is there, ma'am.
The palate is not at all moving.
Ma'am?
Is the palate moving or not moving?
Palate is moving, ma'am. Palate is moving.
Palate is moving.
Palate is moving, ma'am. Only gag was symmetrically movement, ma'am. Palate's movements were present and they are symmetrical.
Okay.
Yes, ma'am. This part I was not able to explain this one.
You see, sometimes it happens in old people, if they had used pawn or the palate becomes less sensitive like the conjunctiva.
Okay.
If they have smoked, you said he was not a smoker, but if they had used substances like pawn, then the palate becomes less sensitive.
Okay. 11th and 12th cranial nerves were normal. 12th nerve, there was no deviation or deviation of the tongue. There is no atrophy or fasciculations that are noted. In the linguals are involved, tongue can become atrophic in the anti-musk, and it produces something called trident tongue. Trident tongue, okay. Trident tongue. So there is a peculiar pattern of grooving that you should specifically look for to know whether it is anti-musk. Okay. Special tests that we had done, because our differential was at the level of either muscle disorder or neuromuscular junction. This was the initial, this was on the resting phase, ma'am. This was initially, and this was then after the ice pack test, ma'am. This was the very good, very good response. Yes, ma'am. And then plus minus sign you're telling, you're opening and that eye is closing. Enhancement of ptosis we demonstrated. Yes, when you open that eye, this eye is closing. I will close, yes, ma'am. Yes. Reverse plus minus. Yes, ma'am. There is no forced abduction was normal. There is no other muscular weakness of any other part of the body. No any proximal muscle involvement in either the upper limb or lower limb. Tick sign was there, huh? Ma'am? Tick sign was there? No. Tick sign, ma'am. Kogan's eyelid tick sign. Kogan's sign was there, ma'am. It was there, ma'am. There. I didn't take a video of that. Okay. Yes. I think some degree of horizontal movement is there, no? Very mild movement or what? I'm unable to see clearly, but I think there is some horizontal movement. It is moving. Okay. Slightly moving. Okay. The vertical plane, it is not at all moving. Not at all moving, yes. Yes. Okay. So we are right, because the horizontal movements are relatively less involved, yes, which is again favoring a neuromuscular junction. Yes, ma'am. Neostigmine test you did, huh? No, I didn't do neostigmine test. It was given, ma'am, but I didn't take this one. There was response to neostigmine, ma'am.
There was no response?
There was a response, ma'am.
There was a response.
There was.
What are the things you should rule out in a senior person like this before you do the neostigmine test?
Cardiac condition we have to see first before giving, ma'am.
Very good. That's what I told you about myasthenia and myopathy. All these cholinergic drugs can produce cardiac arrhythmias. So you have to rule out a heart disease. Second, bronchospasm.
Bronchospasm, yes, ma'am.
They can aggravate bronchospasm. Yes. And if they have peptic ulcer, it can bleed. Okay. So active peptic ulcer, bronchospasm and heart disease should be ruled out before you do this.
Yes, ma'am.
Then tell me, ma'am.
Yes, ma'am.
What else? RNS was done, no? Repetitive stimulation. Other things are all right, no?
Yeah, other things are all right. Pupil was normal, ma'am. There is no obvious sensory deficit that was noted in examination. Motor system examination, there is no obvious change in the tone, power, or reflexes are all normal, ma'am. There are no involuntary movements. Coordination was normal. Sensory system was intact, ma'am. Cortical sensation was also intact. Cerebellar, no signs of any cerebellar involvement. No meningeal signs. Gait was normal. Skull, spine, and carotids were normal, ma'am. Other system examination was also normal.
So after examination, you have no differential diagnosis, only one diagnosis.
Yes, ma'am. You
have got an asymmetrical ptosis, ophthalmoplegia, vertical more involved than horizontal, then pharyngeal face dysphagia with no afferent pathway involvement.
Yes, ma'am.
And good response to ISPAC test and other tests. So there is only one diagnosis, that is neuromuscular junction disease. So at this stage, you should also investigate for paraneoplasty. Very rapidly progressing.
Okay.
Short duration, rapid progression. Yes, so you have to, apart from thymoma, you have to look for other neoplasms also. Then another thing in this situation you have to see is the categorization. You have got myasthenia which may be purely ocular,
yes,
ocular with mild generalized, yes, ocular with respiratory and acute respiratory. That is called Osserman's classification.
Okay.
Osserman classification. So he is having ocular with mild generalized. Yes. So it will come under no respiratory involvement. So it is Osserman class 2. Because if it is purely ocular and it is not progressing for more than 1 year and remains confined to ocular, it is said that you can just give a clip glass and mechanical support and you can avoid drugs when patients are likely to get side effects. Okay. But ocular with generalized, even if the generalization is mild,
yes,
both immunomodulation and medication has to be used. So purely ocular, no thymoma, acetylcholine receptor antibody positive and remains ocular only for more than 1 year, the treatment need not be immunosuppression. Symptomatic treatment can be given if the ptosis is complete, like that. So, but this is not so. Your antibody is positive and he is having class 2. So he needs both symptomatic and immunosuppressive medication. You can start, if it becomes bulbar, becomes severe, or he develops respiratory, you will have to put him on plasmapheresis or intravenous immunoglobulin depending on the availability, and then stabilize and go into immunosuppression with high dose steroids to start with. Simultaneously, second line immunosuppression either with azathioprine or mycophenolate, because these drugs take about 2 to 3 months to act.
Yes, ma'am.
So steroids can be slowly tapered to the lowest level required and maintained with second line immunosuppression, azathioprine or mycophenolate. I feel that azathioprine is good enough. And the symptomatic, because it is cheap, mycophenolate is very costly. And the symptomatic drugs, pyridostigmine, can be slowly reduced if the symptoms become stabilized, and only the immunomodulatory drugs will have to be continued for a longer period of time. In a senior person like this, with normal thymus, no thymic tumor, indication for thymectomy is not clear.
Okay.
The acetylcholine receptor antibody positive, thymic hyperplasia, duration of disease less than 1 year. That is the ideal situation where you get the best results with thymectomy. Thymoma, you have to do thymectomy, but prognosis is not good.
Yes.
So best prognosis is duration of disease 1 year, less than 1 year, female gender, antibody positive, thymic hyperplasia.
Yes.
Thymic lipomas almost give cure. Thymic lipoma, you remove, patient may not need anything.
Okay.
Any other drug afterwards. Thymic lipoma is the curable myasthenia. Thymic hyperplasia is very good if the duration is less than 1 year and the female gender. Thymoma is always bad. So old people with no thymic abnormality, there is a dispute regarding thymectomy. Some people do, some people don't do. If it becomes refractory to treatment, all modalities will be tried. At that time, people might do. But there is no definite indication for thymectomy in a 73-year-old person. You do a mediastinal opening surgery with not much indication.
Not indication. Yes.
So, any doubts, ma'am?
Ma'am,
So, this is a straightforward case.
Yes,
It's not really a nerve. So, we discuss the symptom of the patient. That way, only is good. Anything we can discuss in the neuraxis slowly. When it suits both of you people and me, we can fix appointments. Anything, I am at your service only. So, any doubts you can ask me, ma'am.
Ma'am, what is the
Any
dose
doubt?
of steroids we should start, ma'am?
Which one, ma'am?
Dose of steroids, how much should we start with, ma'am?
Now, dose of steroids, there are two methods. One method is giving high dose steroids to start with.
Okay.
The problem is, you see, steroids will suppress both B cells and T cells. So, but both are abnormal. B cells are suppressed earlier than the T cells. So, and among the B cells, it is a suppressor, T cells are suppressed earlier than the B cells. And among the T cells, it is a suppressor T cell which is suppressed early.
Okay.
So, what will happen is, there is a transient increase in the function of the B cells. Okay. So, they produce an antibody surge. So, if you give a high dose steroid, you should keep the ventilator ready. Okay. Because there is an antibody surge. Okay. Patient can land in the ventilator. But it is said that the period of response to treatment is shortened. But patient may go into ventilator. Okay. But if you start with a very small dose we start with a physiological dose of 7.5 milligram and slowly titrate to maximum tolerated dose and maximum beneficial dose and maintain it like that for full remission for 2 to 3 months and then start tapering. That is very safe. Yes. Okay, but the period needed to induce remission is longer. I do not go into high dose because high dose can land the patient on ventilator. Sometimes it is more tragic than what we expect. To reduce the period of induction of remission, we may kill the patient. So some people do that. I always give low dose. Both methods are practiced. Low dose, slowly titrate, reach the optimum dose needed to produce full remission, maintain a remission for 2 to 3 months, then titrate down and maintain at the minimum dose needed to sustain remission. Some people need about 5 to 7.5 milligram only. Okay. Any other doubt, ma'am? You can post the doubts also if they come later also. Okay, ma'am. Any doubt you can ask. If I know, I will tell the answer.
Madam, some students ask me, I'm Kishan here. Some students ask me, yes, where will your books be available? They tried in online, but it was not available, it seems. So, can you please tell about the availability of books? Yes. And second thing was about the link for your Sunday classes, madam.
Some people have, Vijay has joined our Sunday class.
Yes, madam.
People can join Sunday class. The book, the problem is, as you can see, I am a very unimpressive person. So no publisher was willing to take. I wanted to document Indian data.
It was not like no public. Madam, no public. It's not like no publisher wanted to take. You yourself not wanted to give them because you feel that knowledge is not to be sold. That's why we know that. So you are not willing to give it to any publishers. Instead, you yourself distributing. So how can we avail that, ma'am? Anywhere online?
If anyone wants the book, you just send me their address, ma'am. Then we can give the book. Books are with me only because I invested my money only because I wanted to document what I saw in my life. The data is Indian. The human cognition book is the only comprehensive cognition book in India.
After I posted about that book in the groups. Many asked about the book, ma'am. I had posted about the book in the groups. So many wanted, when they searched in online also, but they couldn't get. So we thought
it is not there in any online. It is in my house only. You can you can give them my mail ID.
Okay.
Let them just mail it to me. I will make it available for them.
Ma'am, and please send us the Sunday class link also.
Yes, ma'am. I will send. Today I will send it to you. This class was useful or what? You all liked?
Very useful, ma'am.
How to analyze double vision and land on a muscle. Something I thought it is very important for you. And how to analyze the symptom of swallowing defect. That you just fix it in your brain. And because it was really not going into one cranial nerve, that aspect we didn't go. We can go in subsequent session. We can easily do, because based on the symptom of our patient, if you discuss only, it becomes useful for you. Otherwise, it becomes theory. So I did like that. So
Balaji, I learned from my NIMHANS friends that madam can teach this cranial on single cranial nerve for days together. On one cranial nerves, teach for days together. That's madam. So anyway, madam, you made it very simple for us. More than everything, we are learning how to decipher, how to diagnose just from with the history, clues from the history, how to come to conclusion. That's what we are learning a lot from you. No need to go for like investigations, or that's all the last resort to confirm or diagnosis. So more of clinical acumen we are learning from you. So thank you very much, madam. Thank you so much. Miss.
I also thank you so much for giving meaning to my life, ma'am. Thank you so much. You can Balaji, no, my mail ID. Anybody wants the books, you tell them to mail me their name and address. I will make it available. If it's not available outside, it's with me only. I will give. I am so grateful. And any case you want next session, we will, when you are not having any other sessions, you tell me, we will have another session. We can go on.
Yes, ma'am.
Wednesdays are relatively free for
me. We are getting very good response in YouTube, madam. Within 3-4 days, we got more than 6,000-7,000 views in our YouTube. We are getting very good response for your sessions in YouTube, ma'am.
Thank you. Thank you so much. Thank you. If you feel it is useful and you are happy, I am also happy. That's all.
We are always happy and grateful, ma'am.
Yes, ma'am. At least we want to learn 1%.
Yes,
thank you so much, madam.
Thank you, ma'am.
At least.
Okay. Inform me when you are free. We'll have next session. Thank you so much. Thanks you. Good night, all of you.
Thank you, Balaji. Wonderful presentation. Yeah.
Thank you. Shall we leave?
Yes, ma'am.